A very good evening to one and all. I am Arpita from the IGCP group. The topic that we are going to cover today in our webinar is Developmental Delay Clinical Approach. I would request everyone to join us for an in-depth webinar that delves into the clinical approach to diagnosis and managing developmental delays. Developmental delays can present in a variety of forms, impacting a child's physical, cognitive, language, or social-emotional development. Understanding and addressing these delays early is crucial for improving long-term outcomes and supporting healthy development. Yes, and we have with us someone very eminent in this field to cover this topic with us. None other than Dr. Bharat J. Parmar, sir. Sir has done MBBS, post that he has done MD, DHA, FAIMS. He is a professor and head of the department at the Zydus Medical College and Hospital, which is at Gujarat. Sir has an extensive experience of approximately 32 years. His special interest in general pediatrics, neonatology, and adolescent pediatrics. He has successfully organized 10 Jan Doctor International conferences. He has been organizing free polio corrective surgery operative campuses since 1997, and he is associated with many organizations. So, with this a very brief introduction of Sir, I will now request him to please start with the session. Over to you, Sir.
Okay, good evening to all. First of all, I am very thankful to IJCP Group give me an opportunity to highlight my views regarding the developmental delay. Developmental delay is fairly common condition seen both in pediatric and specialty care. The identification, evaluation, and treatment of children with the developmental impairment is of a great importance in clinical, educational, and public health setting. Developmental and behavioral disorders in children require early identification and early intervention to improve long-term outcome. In developmental delay, importance of comprehensive evaluation involving medical history, developmental history, physical examination, behavioral observation, and standardized assessment. Pediatricians play a crucial role in early detection, diagnosis, and the management by collaborating with specialists, counseling families, and providing ongoing monitoring and support to the patient. Developmental delay is a condition characterized by delay in learning or language or behavior or motor skill, either singly or in combination. When the child does not acquire milestone as expected for age, he or she is diagnosed as having developmental delay. When the two or more domains are affected, the condition is called global developmental delay (GDD). Global developmental delay affect 1 to 3% population up to the age of 5 years, and even after thorough evaluation and investigation, the cause is identified in only 30 to 40% cases. Increased awareness and utilization of developmental screening tools are essential for timely intervention and better developmental outcome of the children. Understanding and addressing the diverse range of developmental and behavioral disorders in children, such as autism spectrum disorders ASD, attention deficit hyperactivity disorders ADHD, learning disabilities, and emotional disturbance, is a complex and a critical task for the parents, educators, and the healthcare professional alike. Early identification and intervention are crucial for supporting children's healthy development and improving their long-term outcome. The global prevalence of developmental delay in children reported 1 to 3%, while the World Health Organization WHO estimate about 50% of world population live with some form of disability. The causes of developmental delay, the genetic or syndromic cause, there is identified in 20% of those without neurological signs, dysmorphic feature and family history, that is Down syndrome, genetic cause that are less obvious in early childhood, that is febrile fragile X syndrome and mucopolysaccharidosis. The most common is the Down syndrome. Metabolic cause, identified 1% of those without neurological signs, dysmorphic features, and family history. The most common is PKU, there is a phenylketonuria, and MCAD, there is a medium chain acyl CoA dehydrogenase deficiency. The neonatal screening may identify these disorders. Third cause is endocrine. There is a congenital hypothyroidism. Due to trauma, there is an acquired brain injury. An environmental cause lead to the developmental delay, the social economic factor, basic need of food, clothes, warmth, love, and stimulation essential for normal development not met. Cerebral malformation, there is a neuronal migration disorders, there is a cerebral palsy, there is a motor difficulty, and also affect overall development, coordination, developmental coordination, and also dyspraxia. Most common is cerebral palsy. Due to infection, there is a perinatal infection, torch infection, the rubella, cytomegalo, HIV, and neonatal meningitis result into developmental delay. Due to toxin, there is a fetal uh, maternal alcohol and the drug, that's a fetal alcohol syndrome, and due to the drugs in the pregnancy it lead to the developmental delay. And also there is a childhood leg toxicity and the developmental delay. The importance of finding the cause of developmental delay, the family gain insight into the coordination including prognostic information, and it lessen the parental guilt and the mitigate or reduce comorbidities by identifying preventable or reversible factor like to cause secondary disability such as vision and hearing defect, enable genetic counseling focusing on the recurrent risk in the future children. It facilitated to access to the support within the education service and the specific syndrome support groups. And also it helped address the concern about possible risk factor during pregnancy and delivery, and specific treatment may be offered when available. The referral criteria for developmental delay. The early identification of developmental delay is important for initiating early intervention and minimizing risk of future disability. Children suspected to have developmental delay by parent, physician, teachers, and the newborn known to be high risk for developmental delay should be referred for assessment. The following newborn are considered to be the high risk for the developmental delay. There is a very low birth weight, the birth weight less than 1500 gram, neurological condition, there is intraventricular hemorrhage grade 3 and 4, periventricular leukomalacia, hypoischemic encephalopathy, meningitis, persistent seizures, Apgar score less than 3 at 10 minutes, and abnormal neurological condition in the first week of life. So these are the risk factor in newborn for developmental delay. Also, hyperbilirubinemia, septicemia, symptomatic hypoglycemia, the referral criteria are also listed in early intervention guide of neonatal program known as RBSK. There is a Rashtriya Bal Swasthya Karyakram. So treatable cause of mental retardation with the development most two common cause One is hypothyroidism and second hypoglycemia. Child health screening and early intervention under National Health Mission. Under RBSK in children up to 6 years, the birth defect, disease, and the developmental delay and the disability are to be identified and referred to the district early intervention center. There is DEICS. The referral criteria under developmental delay are the vision impairment, hearing impairment, neuromotor impairment, motor delay, cognitive delay, language delay, behavioral disorders, autism, learning disorders, and attention deficit hyperactive disorders. There is ADHD. The presenting clinical features of the developmental delay. The child with syndromic feature and severe deficit is recognized easily and brought to the medical attention early. Otherwise, parents bring children with ID to the healthcare professional due to one and more concern. There is a language delay or immature behavior or play, immature self help skill, learning disabilities, and poor school performance. That some other children comorbidities as autism spectrum disorders, ASD, microcephaly, muscle hypotonia, feeding difficulties, seizures, and behavioral problems such as attention deficit, mood disorders, and sleep disturbance are the presenting features. The component of evaluation, the thorough evaluation of developmental and behavioral disorders typically involve multiple components including medical history, developmental history, thorough physical examination, vision and hearing evaluation, behavioral observation, standardized assessment, parents and teachers report, and collaboration with multidisciplinary team approach. History in the child with the developmental delay. There is a family history of consanguinity, recurrent miscarriage, birth defect, neonatal and infant death, global developmental delay, sibling and family, neurological condition, genetic condition, prenatal history for this developmental delay, extreme age at conception, there is a Mongol, intrauterine infection, torch infection, drugs and medication intake during the pregnancy, maternal diabetes, hypertension during pregnancy, abnormal antenatal scan. This history required prenatally for evaluation of developmental delay. Natal history, there is a difficult transition at birth, gestational age, birth weight, NICU admission, result of newborn screening, NICU event, seizures, jaundice, time of initiation of direct breastfeeding, psychosocial history for the delayed development, the parent education, socio-economic status, parents' drugs and alcohol addiction, child rearing and caretaking practice, and the screen time. How to diagnose this developmental delay? Intellectual disability may be suspected early by developmental and behavioral screening with screening tests performed at 9 months, 18 months, and 24 months, and screening for the autism spectrum disorders at 18 month and the 24-month visits, and the developmental and behavioral screening anytime parents and the clinicians suspect the condition. The clinical evaluation include detailed history, predominantly perinatal history, family history, developmental milestone, as well as physical examination to identify dysmorphism, deficits, and vision and hearing impairment. The commonly used test in evaluation of intelligent quotient in India are the Binet Kamat test, Phatak adaptation of Bailey scale, Wechsler intelligence scale for children WISE, and Wieland social maturity scale, and the formal IQ testing children above 5 years of age. Physical examination in a child with developmental delay, plotting and anthropometry in appropriate growth chart, head, size, shape, frontanil and suture, head to foot examination for a soft sign, there is a dysmorphic face and the transverse palmar crease, congenital malformation, neurocutaneous markers, there is a cafaloid spot in neurofibromatosis, abnormal order, there is a phenylketonuria, PKU, external genitals, ambiguous external genitals, there is a micropenis, and clatomegaly, and systemic examination, there is a cardiac for murmur and abdomen for organomegaly. The neurodevelopmental examination, the complete neurological examination, higher function, cranial nerves, motor system, and the sensory system, and the current developmental status, there is a gross motor, fine motor, language, social, visual, and hearing milestone. Laboratory investigation in case of developmental delay. The blood test urea and electrolytes, creatine kinase, thyroid function test, liver function test, complete blood count, bone profile, glucose lactate, venous blood, and amino acid. Urine test, organic acid, glycosamine, aminoglycan, and oligosaccharides, creatine, and purine and pyrimidine urinary test. Early intervention. The various component of early intervention for early detection, medical management including nutrition of the child, physiotherapy, occupational therapy for a motor delay in case of cerebral palsy, speech therapy for a language delay, also in case of cerebral palsy, special education program, and management of behavioral, emotional, and cognitive problem. Early intervention may focus on the child alone or on a child and family together. It may be center based, home based, hospital based, or a combination of above. The service range from identification, that is thorough hospital and school screening, and the referral service to the diagnostic and the direct intervention program. Rationale for early intervention. There are three primary reasons for intervening early with an exceptional child: for to enhance child development, second to provide support and assistance to the family, and third to maximize child and family benefits to the society. The evaluation of the child with the Global Developmental Delay GDD first perform delayed history taking an examination, second refer for auditory and ophthalmological screening for the deafness and the blindness for the vision, and considered metabolic study, thyroid function T4 and TSH, if universal newborn screening has not been done. In case with a history of suspected convulsion or epilepsy syndrome, obtain EEG of the child and considers screening for autism or the language disorders if there is a close family member with global developmental delay in the sibling or aunt or uncle or a first cousin relative up to the third degree of consanguinity. When there is a history of consanguinity, work out for this autism global developmental delay due to the known metabolic, there is genetic or a structural nervous system disorders and unexplained GDD. So do metabolic screening and also hypothyroid neonatal hypothyroid screening for early detection of hypothyroid and PKU. If this yes, when there is a GDD, perform specific test for that disorders and conduct genetic screening, cytogenetic screening, and consider testing for subtelometric realignment. So there's a karyotyping. And are these features suggestive of specific diagnosis? Are these his- historical or physical finding dysmorphic feature? It suggests Down syndrome, Fragile X or Rett syndrome, and other genetic disorders, and also hypothyroidism. Are these historical? There is a intrapartum asphyxia, physical finding, microcephaly, cerebral palsy, focal finding, and focal seizures, such as CNS injury or CNS malformation. So, are there any identifiable risk factor for excessive environmental lead exposure? There is a lead poisoning and mentored this delayed development, and also consanguinity, prior unexplained loss of child or multiple miscarriage years. So do specific test for that disorders. Also do MRI. If you suspect this lead poisoning, there is a lead screening to for evaluation for this delayed development, and also evaluation of MRI, lead screening, and genetic consultation and this uh, genetic mapping. There is a karyotyping and stepwise evaluation MRI, cytogenetic for the genetic, the Fragile X syndrome, metabolic testing for hypothyroid at phenylketonuria, and test for subtelometric rearrangement. The management of the child with developmental delay. It is a multidisciplinary approach. It required pediatrician, neurologist, social worker, physiotherapist, occupational therapist, speech therapist, clinical nutritionist, psychiatrist, psychologist, genetist, orthopedic surgeon, and the dentist. So manage this developmental delay by multidisciplinary approach. Today's CME, the key message are developmental surveillance and screening should be a part of regular pediatric practice. Use of simple, cultural specific standardized tools for screening 9-month, 18-month, and 24 and 30-month, and when concerns are reported, can help pick up the impairment early. Any child who failed the initial screening test should be promptly referred for a more comprehensive evaluation and to determine the nature and extent of developmental delay and disability. Pediatrician role is not limited to the referral but also periodically reviewing the management plan and developmental monitoring and counseling the parents, and meticulous documentation of all finding, intervention, and outcome is an essential practice for maintaining acute record, tracking the child progress, and ensuring continuity of the care of the child. The global developmental delay is frequently encountered problem in pediatric practice has a wide variety of causes, and the selective investigation are useful in determining the cause, but the cornerstone of diagnostic process is a detailed history and careful clinical examination. Finding a cause confer many medical and social benefits for the child and the family. The recent technological advance, especially in genetics and neuroimaging, have highlighted the importance of reviewing the need for repeat and updated investigation. Empathetic counseling and effective communication to the family are extremely important, and the child development unit play big role in a rehabilitation of children with varying disability, providing assessment and therapeutic intervention to optimize the outcome. An early intervention consists of provision of service for such children and their family for lessening the effect of condition. Thank you.
Thank you, sir. Thank you so much. Hello.
Hello.
Yeah, am I audible to you, sir?
Yes.
Yeah. So thank you so much for this presentation.
Hello.
Yes, sir. Sir, can we take the questions now?
Yes, yes.
So here I'm going to the first question, that is, what are the key early signs of developmental delay that pediatricians should be vigilant about during routine checkups?
So if the most common endocrine disorders in children is a congenital hypothyroidism. So in history taking, if there is a prolonged unconjugated hypolipoproteinemia or delayed passage of meconium, and on birth weight is large birth weight. This is important in birth history, and there is a most early signs in case of congenital hypothyroidism. There is a open posterior frontal at the age of 6 weeks. These are the early signs of hypothyroidism. Later on, there is a creatine, and there is a dry scaly skin, and the uh, temperature is also subnormal, refractory anemias, right, and delayed development. Secondly, most common cause CNS, there is a cerebral palsy. So in cerebral palsy, there is a certain condition, but uh, in the early neonatal period, there is a hypoglycemia is there, septicemia is there. Then it lead to there is a delayed development. So if there is a prolonged this unconjugated hypervolemia more than 20 milligram percentage, and if you do not give extent transfusion, it lead to the kernicterus and development of cerebral palsy. So in this cerebral palsy, there is, if you examine in the newborn, there is a scissoring is there. Also uh, fisting of the this hand, wrist, and also these primitive neural reflex, they persist after more than 4 months. It's suggestive of the delayed development. So two most common cause is cerebral palsy, and one is a hypothyroidism.
Right, sir. Right. Thank you. Thank you so much, sir, for answering this query. Moving on to the next question. How do you counsel parents of children with developmental delays about long-term prognosis and the importance of multidisciplinary care.
So first to find out the cause, the what is the cause of the delayed development? I already told the most common pertaining to endocrine it is hypothyroidism. Second, metabolic cause most important is a phenylketonuria. The third CNS cause most common is cerebral palsy. So to find out the cause and according to the cause, if there is a cerebral palsy, it associated with this most common with the seizures. There is epilepsy and also associated learning disabilities, also blindness, deafness, and whatnot. So, as a multidisciplinary, if the cerebral palsy having only these motor delays there, then advise about the physiotherapy and occupational therapy. If there is squint is there, then refer to the ophthalmologist and also for the vision. If the deafness is there for hearing impairment, send to the ENT surgeons. If there is any limb abnormalities there, right? In case of cerebral palsy, sent to these orthopedic surgeon. If there is a cerebral palsy, children having dental caries, uh, take advice about the dentist. And also in cerebral palsy, due to these feeding difficulties and the lack of movement, right? So feeding difficulty, the child become sometimes malnourished. So also advise about the feeding. So take advice about the nutritionist about the nutrition. So according to the cause, advise the child for appropriate management.
Right, sir. Thank you so much. So the next question is nowadays, as we see, the babies are glued to the mobile phones. So, what is the
Uh,
role of screen time in
when
developmental
there is a
delays?
long screening time is there, there is a due to the constant radiation, uh, and there is a damage to this brain. It lead to this developmental delay. There is a cognitive developments. So reduce the screen time for these prevention of these brain damage.
So, in case of a speech delay, how much delay is considered likely, and how much needs to be checked into?
Up to 3 to 4 years. Then take advice about these ENT surgeon and the speech therapist.
Right, sir. Sir, how do you approach different diagnoses in developmental delay, particularly distinguishing between conditions like autism spectrum disorder, the global development delay, and cerebral palsy?
If there is a cerebral palsy, I already told there is a different consequence of cerebral palsy. If there is a it associated with this seizure associated with epilepsy seizures, then take this EG and the MRI is there. If there is a hearing defect there, then ENT surgeon to rule out any abnormality due to these connectors. If there is a speech defect is there, take advice about this ENT surgeon and the speech therapist. So according to this disability, patients should be advised, take advice according to their cause of this delayed development.
Sir, one last question. That is the Could you describe the most effective screening tool for assessment and identifying development delay in infant and toddlers?
So most important for the early detection, so this metabolic screening is important tools to diagnose there is a hypothyroid early or the phenylketonuria early. So there is a neonatal screening program should be implemented.
Right, sir. And sir, there is one more last question. What role does early intervention play in improving outcome for children with developmental delay? And what strategies do you find most impactful in clinical practice?
So, if the early identification, if there is a case of hypothyroid, if you detect within 4 to 6 weeks, diagnose hypothyroid and start this thyroxine, then because maximum brain growth from 18 month to 24 month. So if you detect early hypothyroid within 4 to 6 weeks, then there's a outcome is good. If you detect this development, if the cerebral palsy is there, there is a delayed development. Uh, 1 year there is a no development, any development in child, then you suspect the global development delay and take this advice. There's a multidisciplinary approach applied for this global developmental delay. If there is a hypoglycemia is there due to septicemia or delayed breastfeeding, so you should suspect this hypoglycemia. So advise this early breastfeeding for prevention of hypoglycemia, because it due to this minimal brain dysfunction. So advise early breastfeeding to rule out this prevent hypoglycemia. And if there is a hypoglycemia, they're symptomatic. So management of hypoglycemia and prevent this. So two most common preventable cause of mental retardation is one is hypoglycemia and second is hypothyroidism.
Right, sir. Right. Thank you, sir. Thank you so much for answering all these queries. With this, we come to an end of the session. And thank you so much, sir, for giving us your valuable time, sharing your knowledge, and giving us this insightful session. Thank you so much, sir, once again.
Okay, thank you. Good day.
Thank you. Same to you, sir. Thanks
Okay,
to
thank
all
you.
the audiences for joining in and making it a successful one. Thank you all. I'm closing the session now.
Okay.